Good afternoon, everyone, and welcome to today's webinar hosted by HFMA Region 10 chapters. This is part 4 of a 4-part Medicare Bootcamp webinar series. The discussion for today is Reimbursement Compliance Foundation. I would like to welcome today's guest presenter, Ryan Thurber, Associate at Polsinelli, PC. Healthcare providers of all types face unique challenges presented by an extremely complex and ever-changing regulatory environment. Ryan's practice focuses on helping providers achieve their business objectives in a manner that clears these regulatory hurdles and allows providers to do what they do best, care for their patients. As a part of Polsinelli's vibrant healthcare practice, Ryan assists providers with resolving complex regulatory compliance issues and responding to government and third-party investigations, audits, subpoenas, and other inquiries. So, without further delay, I'd like to hand the call over to today's guest presenter. Ryan, please go ahead.
Hey, thank you so much. Good afternoon, everybody. My name is Ryan Thurber. As Nikki said, I am an attorney here in Polsinelli's Denver office. And you are indeed at part 4 of the Medicare Bootcamp series that HFMA sponsors every year and works with everybody on. Before we get started, I want to put in a plug. We put together the Bootcamp series as a way to try to introduce some sort of foundational understanding of compliance and reimbursement and billing processes on an annual basis and do this series as an annual tool that's available for our constituents to listen to as we work to make this program better every year, to make it more responsive to your needs and your requests and what is really going to be helpful for you. Your feedback is really, really important. So I think you'll have the opportunity at the end of this session to provide feedback on content, but also more generally, if you have a moment, please take time to fill out the surveys related to these sessions. If there is something about them we can be doing better, if there's different or additional content you want to hear about or learn about, please let us know. We really do pay attention to those, and we really will try to make sure that we are tailoring this program to really suit your needs. If you don't have time to do the full survey, my email is also on here, and I help plan this session every year. So if there's some other kind of feedback you want to provide, please feel free to shoot me an email, and we'll be more than happy and really excited to take that feedback into consideration for next year. With that out of the way, all the preliminaries done, let's go ahead and get started. Here's sort of where we're heading today. For those of you who work every day in compliance, and from looking at the attendee reports for the last few years for this session, we get a really kind of a wide variety of people with different backgrounds and experiences. So if you already work in compliance or you're in charge of your organization's compliance program, this session is really intended to be an introductory session to the sort of foundational compliance principles that every organization needs to take into account and consider as they develop their compliance program and as they think about how to handle compliance issues when they arise, because they do from time to time. You just can't help it. So that being said, if you are someone who has been doing compliance for a long time, or if this is your bread and butter, consider this an opportunity to take a step back from your current compliance program, to reevaluate the priorities that your compliance program has set, to think about policies and procedures in a new way. The challenge with compliance programs is once you've been running them for a while, they can get into a rut and they can start to have a pattern to themselves that can make it difficult to adapt to new changing environments or to new regulations. And so even if you are already sort of old hand at compliance matters, there's always room and always a good time to take a step back and consider what might be changed or what might be improved or what might be tightened up, because there can be no doubt that healthcare compliance is an ever-changing and evolving field, and it's something that keeps all of us on our toes and all of us awake at night. So today we're going to talk about a few sort of high-level basic compliance principles. We're going to have an introduction and talk about the False Claims Act and some of the other laws that impact healthcare compliance. We're going to talk about overpayments and refunds. Because this is the HFMA program, where there's going to be a heavy focus today on reimbursement related issues and revenue cycle related issues, which you might anticipate from the sort of core constituency for our audience here. That is not to say that compliance programs only focus on those things, but that's going to be sort of our focus today. We'll talk about building an effective compliance program, the elements that the government has identified to help providers really establish an effective compliance program, and also talk about sort of the process of building a program. This is another opportunity for those of you who work directly in compliance to think about where on the continuum and where on the life cycle of your compliance program that your particular efforts fall. And then finally, because we, again, have a wide range of people who listen into these sessions, we're going to talk a little bit about frontline kind of compliance efforts. So for those of you that are listening now that say to yourself, well, I'm not a compliance officer, or I'm not, I don't work in the compliance department, what does this have to do with me? We're going to spend a few minutes talking about exactly that, because the truth is, and we'll talk about this more later on, you're the most important part of an effective compliance program. No matter how involved a compliance officer is, no matter how detailed a compliance program, no matter how robust the policies and procedures are, without investment from the people who interact with government or people who work in healthcare operations on a day-to-day basis, compliance programs just can't work. So we need your help as well, and we'll spend some time talking about things that you can do on a practical level to help your organization out. So the first big topic we're going to cover is the False Claims Act, and this is not the only driver of healthcare compliance and not the only reason to have an effective compliance program, but the False Claims Act is by far the largest hammer. And when you hear about large settlements or big judgments in healthcare compliance issues, they almost always, not always, but almost always are tied in some way to the False Claims Act. The False Claims Act is a statute that was originally promulgated during the Civil War because a whole bunch of people were defrauding the Union Army and were sending guns that wouldn't fire, or crates of food or ammunition that wouldn't work or that weren't edible. And so the False Claims Act was passed essentially to put a stop to all that fraudulent activity. It has since survived the post-war period and is now really a key tool in the government's arsenal when they fight healthcare fraud. The idea behind the False Claims Act is that it penalizes the knowing submission of a false or fraudulent claim to the government for payment. So in the Civil War, that meant billing the government for crates of ammunition. Today, that means submitting claims to the Medicare program, the Medicaid program, or a whole bunch of other different programs for healthcare services furnished to government-sponsored payer beneficiaries. It's important to note, and remember this for later if you would, that knowingly also includes a reckless disregard or willful ignorance. So it's not enough just to say, as an organization, we had no idea that we were submitting false claims related for whatever reason. It's also important to realize that you can't just bury your head in the sand either, because the government can also come after you if you're just not paying attention and you're not doing something that you should be doing, and that rises to the level of recklessness, essentially. So there's going to be a False Claims Act allegation against your organization. It's going to come in one of two ways. The first, there could be a direct government investigation. The second is what's called a key tam lawsuit. So the direct government investigation is as you might expect. The government shows up at your facility and says, we think you have committed healthcare fraud. Please comply with a document request, and you go through a very long process. The key tam lawsuit is different. Key tam lawsuits are brought by private citizens in the name of the government. They are known as relators, and essentially what happens is any private citizen can file a lawsuit on behalf of the government, alleging that there has been some type of false claim presented to the government. And this doesn't have to be healthcare either. For the record, like defense contractors, all kinds of government contractors can get in trouble under the False Claims Act. But healthcare is a fertile ground for these types of lawsuits. And what will happen is the key tam relator will file the lawsuit on their behalf. The government will have a chance to look at the claims that are brought against the healthcare organization by the relator, and they can decide whether or not the government also wants to participate directly. The government doesn't have to. They can decline to do that, and that means the relator can bring the case on their own, or the government might intervene and take over the case themselves. It just depends on the facts and circumstances of the case, whether or not there's a really good case. But in any event, the case can go forward whether or not the government decides to intervene. As I mentioned, the False Claims Act is really the largest hammer that the government has to go after healthcare fraud, and here's why. If you are found to be liable for a False Claims Act violation, there's a couple of really steep penalties. The first is you get triple damages based on the amount of money the government paid inappropriately. So if you imagine for a moment that your hospital, for example, has submitted a artificially inflated claim for one type of DRG that charged the government more than they should have, and that happened repeatedly over and over and over again over the course of, let's say, 2 years. However much additional money the government paid as a result of that billing error, they're going to triple that, and that's just the base damage. When you really get into trouble is they are also available to the government penalties, and these are adjusted upwards every year annually for inflation of up to $22,363 per claim that you've submitted to the government. Those of you that work in revenue cycle, that work in reimbursement, you know how many claims get submitted by healthcare entities on a day-to-day basis. Those numbers add up so fast to the point where a really negative False Claims Act outcome absolutely threatens the existence of an entire healthcare provider because the numbers are just too astronomical. You can get up into the hundreds of millions of dollars very, very easily. The other challenge for healthcare providers is there's a lot of ways to wind up in False Claims Act territory. As I mentioned, there's outright fraud, right? There's you can, bill the government for services you never actually furnished. You can bill the government for crates of ammunition that don't work. That's fraud. That's clearly within the scope of the statute. There's also a lot of other more technical violations that can have you wind up in the same place. Simple billing and coding errors. That might happen because there's poor documentation by a physician of the services that were provided. It might happen because you have a computer error. It might happen, as we'll discuss later on, because the government has a computer error. You can have AKS or Stark violations, so inappropriate relationships with referral sources or particularly with physicians. You might not meet certain Medicare regulatory requirements, such as the conditions of participation or conditions of payment for your type of provider. You may wind up not having the right kind of documentation to support the medical necessity of the services your facility is furnishing, or you might be providing services the government thinks are unreasonable. We've seen an uptick in that recently, and that type of enforcement from the government. Or you might, as we'll talk about in more detail in a minute, be found to be improperly retaining an overpayment. Any of these items can lead to False Claims Act liability and can lead to a lot of trouble, which is why having an effective compliance program is just so important. As I mentioned before, successful FCA lawsuits result in significant settlements. So the Department of Justice for fiscal year 2017 recovered $3.7 billion from False Claims Act cases by themselves. $2.4 billion of that was from healthcare. Over a 3-year period, this data is a little old, but I think the trend still continues. The Office of Inspector General for the Department of Health and Human Services realized a 5-to-1 return on investment on their money they spend investigating healthcare fraud. In other words, for every dollar they spend investigating, they get back 5. With that type of return, there is no incentive for the government to let up. There is no incentive for the government to ease up on investigating providers. It's frankly lucrative for them. So here are some examples. These are just all within the last month or so of settlements. Some of these are the False Claims Act, some are just more outright healthcare fraud. The first one, the Health Right LLC, 4 individuals, 7 companies, they were indicted based on a $1 billion estimated telemedicine fraud. The facts and circumstances behind that related to essentially soliciting illegitimate pain cream and other prescriptions from customers, getting physicians to sign off on them without realizing that they were illegitimate, and then massively marking up the price of the pain creams and the other prescriptions they were furnishing to those patients. I highlight this one for a couple of reasons. The first is there's a new trend, or relatively new trend, in False Claims Act enforcement and government healthcare fraud enforcement to not just go after the healthcare entity, but to also go after individuals who are responsible. There was a memo that was written by Sally Yates a few years ago, specifically directing the government and directing the DOJ to go after individuals and to seek, as part of the settlement negotiations, individual liability for this type of behavior. So it's no longer enough that the legal entity is going to act as a shield for whoever's involved. There's now going to be a target on individuals who have influence or control over the fraudulent conduct. And that's something that is continuing to this day, even though it's been now a few years since that memo was published. Second settlement, AmerisourceBergen, related to repackaging of cancer drugs. They allegedly were essentially buying vials of cancer drugs, pooling all of them together and then repackaging and misbranding them and selling them. You'll notice the theme here, almost all of these cases settle. And even though they settle for large amounts, $625 million, $260 million, the settlements are far less than what a judgment would be. So when you see these massive numbers, just remember to yourself, this was the best possible outcome from the provider's perspective, because if they had gone to trial and lost on the False Claims Act allegations, it would have gotten much, much worse. Kalispell Regional Health System, this is a smaller dollar figure, but I wanted to point out too that here, this is an example where we have still improper physician compensation arrangements that lead to False Claims Act allegations. In this case, the allegation was that they were paying essentially full-time compensation to a bunch of physicians who were not in fact working full-time. Health Management Associates, this was another sort of a mess, but this also relates to a lot of reimbursement issues, a $260 million settlement. This was based in large part on allegations that the company as a whole was pressuring their physicians to admit more people than would be medically necessary from the emergency department to the inpatient wards of their hospitals, essentially to drive up reimbursement. There was also a few kickback issues with physicians where they were alleging they were providing free office space, and some other allegations along the same lines. You know, I offer these as examples not to scare anyone or to try to sound alarmist about anything, but I want to make it clear that enforcement in this area is active and it's ongoing, and it's not likely to slow down anytime soon, particularly given how lucrative it is for the government to pursue it. Before we go too much farther, there are a few other key laws to be aware of. These are less directly related to sort of reimbursement issues, which is why we're not going to spend a ton of time on them today. The Stark Law and the Anti-Kickback Statute can be webinars all unto themselves, as could the CMP Law. But that's just not what we're here for today. But at a very basic and high level, the Stark Law regulates essentially your relationships with physicians. It applies only to physicians and only applies to certain health services. But it essentially creates a framework within which you need to structure those physician relationships in order not to violate the law. The thing about the Stark Law that's important to remember is that it's strict liability. There is no intent element to the Stark Law. There is no, well, I didn't mean it, or I didn't want to pay the physician for his or her referrals, or I didn't want to do any of these things. If you do not meet an exception to the Stark Law, you violate the Stark Law. It's more like a speed limit. If you're going 56 and 55, you are speeding, regardless of whether or not you meant to or not. On the flip side of that is the Anti-Kickback Statute, which can be civil or criminal, but is in fact intent-based. It functions in a similar manner to the Stark Law, but it regulates a far broader spectrum of relationships. So the Anti-Kickback Statute prohibits paying or receiving any kind of remuneration, money essentially, or anything of value, in exchange for referrals. So it applies to any potential source of referrals for federal health care program business. So if you are a hospital and you have a relationship with a nursing home, or you have a relationship with a DME company, or you have a relationship with another hospital, any of those types of financial relationships can be subject to the Anti-Kickback Statute. The good news is it's intent-based, which gives you some more flexibility in terms of how you think about how those structures work. But at the same time, you still need to be careful. Like the Stark Law, the AKS has what are called safe harbors, which essentially create, again, a framework to structure these relationships in a way that will be compliant with the law. Finally, the Civil Monetary Penalty Law, also known as the Beneficiary Inducement Statute, essentially prohibits bribing beneficiaries to come and use your particular healthcare provider. There are, again, a number of exceptions to this law, and a lot that can be taken advantage of, particularly if you are looking to improve access to care, or if you're involved in value-based care arrangements. But this is also something to be aware of if you're dealing directly with your relationships with beneficiaries. So because this is the HFMA series, and because reimbursement is really a focus that we're having today, we're going to talk a little bit about overpayments, because overpayments remain an area of increased focus for government enforcement, remain an area of increased potential liability for healthcare providers, and it's also tied directly to your revenue cycle and your reimbursement operations at all your facilities. An overpayment is essentially, and it's defined absolutely this broadly, any funds received by a person that the person was not entitled to receive. In practice, in reality, this can happen in a whole bunch of different ways, right? You might get paid for a non-covered service, one that you shouldn't have been paid for. You might get paid in excess of the allowable amount. If there's a fee schedule and you get paid more than that, that delta is an overpayment. If you might have a cost report error or issue, you might have a duplicate payment, or you might have a Medicare secondary payer error. There are an almost infinite list of potential reasons that an overpayment can happen. And it's important for providers to have a process and a procedure in place to address overpayments when they happen, and to figure out how to calculate and quantify them in a way that's going to be meaningful. Once a provider has identified an overpayment, once we have realized that we've been overpaid for something, you have to return them to wherever they're supposed to go within 60 days. There's a definition for identification of an overpayment. There's a definition for almost everything in healthcare regulatory compliance. But in this case, an overpayment is identified when a provider determines that it has in fact received an overpayment and has been able to quantify the amount, and we'll talk about that in a second because that's important. Or, alternatively, if a provider should have determined and quantified that there was an overpayment through the exercise of reasonable diligence. We're going to pause here for just a second because there's a couple of things to be aware of. The first is, if you remember from early in the slide deck, we talked about the standard for False Claims Act liability, and that's what happens if you have an overpayment that you retain too long, it goes to false claims territory. And the standard in False Claims Act land is you have to knowingly submit a false claim to the government, and that includes reckless indifference or willful misconduct, essentially. Through the exercise of reasonable diligence doesn't seem to rise to quite the same level. And in fact, a court has agreed. There was a recent case that was brought by United Healthcare where they challenged CMS's final overpayment rule and regulation that included this language as applied to Medicare Part C, which is Medicare Advantage. And the court actually said, you know what, you have in fact, by including this exercise of reasonable diligence language, you have in fact applied essentially a negligence standard, which is a lower standard of liability to the False Claims Act, which requires a knowledge standard, a higher standard of liability. So CMS's rule on that front, as applied to Part C, as applied to Medicare Advantage, has been severely limited. That does not mean that applies to Medicare Part A and B necessarily, but it is something to be aware of as an avenue for a potential defense if you ever wind up in hot water over an overpayment issue. At the same time, unless and until someone brings that challenge, and unless until we get a court that says this standard as applied to the Medicare Part A and B is also inappropriate, following the guidance that CMS has already published is the right way to go, just to make sure that we have done everything we can as providers to make sure that we are being diligent in identifying and returning overpayments. So, all of that pause to say there has been some challenge and some ambiguity and some uncertainty about how an overpayment is identified through the exercise of reasonable diligence. But for now, keep on keeping on, but keep your ear to the ground to see if there are any changes to this in the coming months. So reasonable diligence is a multi-step sort of process for providers. The first part of it, obviously, is you get some kind of credible information concerning a potential overpayment. If there is, as a result of hearing from someone, it might come through your compliance program complaint line. It might come because you saw that your check from Medicaid or for Medicare for that month was twice what you thought it was supposed to be. And there's a lot of different ways that you might find credible information about an overpayment. But once you have it, You need to exercise reasonable diligence to investigate and see what happened. Did we get more money because we in fact furnished care to sicker patients? Did we get more money because we in fact had more patients this month? Or did we get money because in fact Medicaid had a billing and reimbursement error and paid us at twice the fee schedule rate? There are a lot of different possibilities, and it's your job as a provider to do diligence in investigating that information. Once you're doing while you're doing your diligence, rather, you will take that time to identify and then quantify any potential overpayments. That means you have to take a look and figure out exactly, okay, there was an issue. It was for this set of claims over these 6 months or so, and that results in an overpayment of X. You'll take that information to really build a concrete understanding of what the overpayment might have been. Then once you've identified all that information, it's time to report and return. CMS has suggested that in their guidance, again, that you should do investigation essentially with all kind of reasonable speed, but they anticipate that it shouldn't take really any more than 6 months to do your investigation. Most investigations won't take that long, and that's also not necessarily a hard and fast deadline. In other words, if you were doing an investigation and it takes more than 6 months, that's not necessarily fatal, but at that point, once you approach 6 months, you want to start documenting and thinking about how you support why the investigation is taking that long. Maybe there are just a lot of claims, maybe there is a very fact-specific inquiry that you're required to do, or maybe it just has been provider turnover for employees. There are a lot of different reasons. But once you get close to that 6-month threshold, that's when you want to start thinking about documenting the steps that you're taking to demonstrate, if someone ever asks, that you are in fact conducting a reasonable investigation. Overpayments are only identified following this investigation. So as I mentioned before, there's a 60-day clock once overpayments are identified, but that clock doesn't start until the investigation is complete. And moreover, if you're doing a probe sample, which is a perfectly reasonable thing to do, particularly if you have a very large claims universe you need to investigate, your overpayment's not identified until you've actually done the full claim analysis. So if you do a probe sample and find a 10% error rate, and you say, okay, well, this is significant, we need to do the rest, you're not on the clock until you've had a chance to actually quantify everything under those circumstances. So once you've identified an overpayment and figured out that there is, in fact, an obligation to pay some money back, there are a number of different ways that happens. Every MAC has a voluntary refund process. If you Google it for your Medicare administrative contractor, you can find it and pull it up. Depending on the timing, you may also just be able to request a claim adjustment or an offset, and that is administratively simpler for you. That also works. If it's a Medicaid issue, Medicaid programs all have their own special process consistent with Medicaid operation on a state-by-state sort of basis. So you have to check on that. But there will be a Medicaid overpayment return process. The 60-day overpayment clock that we talked about is also told you can request an extended repayment schedule from whoever it is that you're funding the money to. And if they agree to that and you work out a plan with them, your 60-day clock is no longer, doesn't no longer apply to you. And also, you can also use an approved disclosure method. There's an OIG protocol for kickback issues. There's a CMS process for Stark violations. If you go through one of those protocols and you disclose everything to the government, that also will toll the 60-day clock. Finally, CMS's final rule for overpayment set the look-back period at 6 years. So that means if you discover an issue that's been ongoing, and maybe it's a computer system error that's been around for a long time, or maybe there's some kind of other larger systemic issue, the outer bounds of what you're supposed to be looking back at are now under that rule 6 years. Keep in mind that's Medicare Part A and B. The other rules are not quite as solid as that, and state Medicaid programs may also have different thresholds. So if you have a Medicaid issue, you really got to do sort of a state-by-state specific analysis and figure out what your obligations are going to be. So that's overpayments. We're going to take a sort of shift here and talk more about compliance programs generally, how organizations build them and how they work, and how you can participate in them. So compliance programs are absolutely crucial and vital to the long-term sustainability of healthcare providers. You know, False Claims Act settlements or other types of settlements can just be so large and so onerous that if you don't have a good compliance program in place to catch some of these things up front and mitigate the risk in advance of having to fight a lawsuit or fight a government investigation, it can threaten the very continuance of your provider. They just may not be able to exist anymore. I don't know, there aren't very many healthcare companies out there that could absorb a $625 million settlement or a $260 million settlement. It is very difficult to manage those things without having a compliance program that's set up to help you catch these things. Compliance programs are not just focused on billing and reimbursement, though that's what we're talking about today. It's also going to include, your fraud and abuse compliance, which is going to get to Stark and AKS issues, compliance with conditions of participation or coverage for your healthcare provider, and just a really wide variety of issues. Again, the goal is, to the extent possible, to catch and identify compliance issues up front before they're allowed to extend for long periods of time, before they are public, before the government is involved, to catch, identify, and correct. And if necessary, make a disclosure or make a refund, but do all that up front and demonstrate to the government, if necessary, that you are taking steps as an organization to operate in a compliant way and to really operate in good faith and compliance with the laws that apply to you. The HHS Office of Inspector General has published guidance to help providers develop their compliance programs. These are based on, just based on the constituents we have here. These slides are based on the hospital version of that guidance document, but there are versions of this document for just about every type of healthcare provider, for physician practices, for SNFs, for almost any type. So take that for what it's worth, but if you are not at a hospital and you are a different type of healthcare provider, there is guidance out there for you as well. The core concepts are very similar, which is why we can just cover one and get most of it. But there will be language in those guidance documents that is specific to your type of facility, and particularly where the OIG talks about risk areas. So SNFs have a different risk profile than hospitals do, and they will talk a little bit in those documents about the various risks that those organizations face and how to counteract them. So we're not going to go through the list here because we're going to talk about each of them in detail, but you can see there are basically 7 elements of an effective compliance program that the OIG wants to see if they're evaluating you. The first element is written policies and procedures. One theme that you'll hear me say throughout this presentation is that you have a wide degree of latitude as a healthcare provider to tailor your policies and procedures, to tailor your compliance program, to tailor your disciplinary policies, everything to the scope and scale of resources you have as a provider. A multi-state hospital system is going to have a very different compliance program than a small group physician practice or a small lab or whoever else. There just is a variety of resource levels and a variety of ability to devote time to this that exists, and the OIG recognizes that that's going to be the case. What you should do, however, when you develop your policies and procedures is focus on particular areas of risk for your type of healthcare provider. Some examples might include standards of conduct for your employees, claim development and submission policies, policies related to medical necessity, not just that you're going to furnish medically necessary services, but also how you document those things and how you make sure that the services you're furnishing are going to meet those federal and state standards for necessity. Financial relationships with referral sources, reimbursement related policies for financial integrity, so bad debt reporting, credit balance evaluation, record retention. Another important one, particularly as you deal with investigations that date back, more than a year or so, because you have to worry about how you go back and actually prove the services you furnished were medically necessary, were supported by medical evidence, were appropriately billed, etc. And then finally, compliance is an element of performance. You see this more and more at healthcare providers, but actually incentivizing employees to operate and to work in a compliant manner, and having that be part, in fact, of their job description and how they're compensated. The second element is the more formal structure for your compliance program. A compliance officer is a really important part of developing an effective compliance program because they act as the focus for the program's activities and act as the sort of point person for the organization to make sure that someone's always at least keeping their finger on the pulse of compliance activities. Again, the structure around them can vary and will vary based on the size of your organization, and you can feel free to use existing process and resources. If you have to have a compliance officer that wears a different hat also, that's okay. But the important thing is to put in place that formal process. If you have the resources or you have the size of the organization to have a committee that assists the compliance officer, that's also something that can be helpful because it takes some of the stress and the strain off of a single person and allows that responsibility to be distributed. But the compliance officer is going to be reporting into your organization's leadership on compliance issues. They will manage your internal audits and reviews, and will just in general be responsible for helping your compliance program run smoothly. Once you have that kind of formal structure in place and you have the policies and procedures, training your employees is also very, very important. It doesn't do you any good to develop the world's best policies if no one in your organization knows or understands how to implement them or what they mean or what they in fact require. So training your employees is very important. You should train them at the outset of their employment during orientation, and you should also ensure there's an ongoing program to make sure that employees are both refreshed on existing policies and procedures and plans and programs and methods of communicating, but also because healthcare compliance changes so often. They need to be regularly updated on new developments and new regulations and new requirements so that everybody is working together on the same page. Effective communication is also important because if the compliance program is not accessible to your employees, you're not going to actually find out about compliance issues before it's too late. If there's a perception that the compliance program exists in name only, or if there's a perception that the compliance officer or the program is not approachable by the employees, if the employees feel like they will get in trouble for reporting something, or if they feel like they will be punished or retaliated against, you're not going to have an effective compliance program, and you're going to wind up with more issues that become external and that you can't manage internally. For that reason, you need to have open access to the organization's compliance officer and the program. If it's a small organization and it's just an open door policy for the compliance officer, great. If you have more resources, consider anonymous methods for reporting, a hotline or something else like that, or a Dropbox for complaints. Anything that you can do to encourage your employees to report suspected issues, and so that you can follow up on them, investigate them, the better. Again, part of the issue is the False Claims Act allows private lawsuits by third parties. And so if you don't develop a line of communication, if you don't develop a program that is open and welcoming to your employees and they feel like they are part of it and invested in it, that's how you wind up with relators instead. Disciplinary guidelines. No one likes discipline, but discipline is an important part of the compliance program process. Again, this is an area where you have quite a bit of latitude for how you set and establish these policies for your organization. They don't need to be overly punitive or overly harsh, especially not at first. But there needs to be a process and a plan in place, and it needs to be meaningful and it needs to be effective, so that when there are in fact compliance-related issues, those disciplinary policies are in fact enforced. One of the things you'll hear me say over and over again is it's actually sometimes worse to have a policy and not enforce it than to not have a policy at all. So have good disciplinary guidelines in place and be prepared, in fact, to enforce them if there is ever an issue. Auditing and monitoring is one of the more important ongoing functions of your compliance program. Again, as with all of these things, this is scalable to your organization's size and complexity. So a large health system is going to have a much different and much more robust auditing schedule than a smaller hospital or a physician practice or whoever else, because there's just, again, an issue of resources. But what you want to do for auditing and monitoring is, again, make sure that you target areas where you have greatest risk as a healthcare provider, where you have the greatest exposure or where maybe you have been historically weak as well. If there's been sort of an ongoing issue with documentation of medical necessity, for example. That would be an area where your compliance program would want to have increased focus on auditing and monitoring until you are satisfied that the issue has been resolved. Effective auditing and monitoring is also, it's both proactive and reactive. So if you hear an issue through your compliance hotline, or you learn of something and you need to do an investigation to see if there's an overpayment, for example, then you need to absolutely do those, but those are reactive audits. It's also important to develop a proactive audit program that, as I said, is focused on areas of particular risk for your organization. And when necessary, you should consider the use of outside resources. And that may be because you need to do an in-depth review, and that's more than you can handle internally. Maybe it's a political issue and within your organization, and it just will make more sense, and the audit will be more complete and more independent if it's done by an outside party. That's a judgment call that your compliance officer can make, or that you can make, and just something to consider and keep in mind as you think about your monitoring program when it's appropriate to use outside resources instead. So once you have identified an issue, it's up to the compliance officer to investigate. And again, the government's going to want to see if they ever evaluate your program, or they ever have to work with you on an issue, that you have in fact taken action as an organization to address issues that you've learned about. You need to again consider the appropriate use of internal or external resources. Maybe if someone's internal is involved in what we're investigating, we need to use an outside person. Maybe if we think it's a relatively small and discrete issue, or if we think it's something that is we understand what the issue is, then we just handle it internally. There's a lot of factors that go into that decision. If you figure out that there's a problem, and you figure out your investigation leads to the conclusion there's an overpayment, or that there's a Stark issue or something else, you need to make the appropriate refund or disclosure to government agencies. You can't just sit on it. There have been plenty of cases where healthcare providers have learned about potential issues and have figured out there was probably a problem, and even at the point of having a spreadsheet that laid out specifically what those problems were believed to be, but ignored it and put it aside, put it in a drawer, and left it alone, and then wound up being called to the carpet for it later. You also need to make sure you're responding with reasonable speed. Again, not just in the overpayment context, but you want to make sure that you are in fact moving forward and you can demonstrate progress. If there's a reason why an investigation takes a particularly long period of time, make sure that you have the documentation for that and you understand that and can explain in a meaningful way why the investigation took as long as it did. So those are the sort of kind of key elements and building blocks of the compliance program. And as we talk about next how to implement these programs and how to think about structuring them, keep in mind that your organization can be anywhere on this continuum we're going to describe. And we use a metaphor of flight to describe the kind of stages. But your organization may fall anywhere along this timeline. And that's okay. The really important thing is to keep kind of moving forward and keep improving and keep tweaking and refining and tailoring your compliance program over time to build out sort of the full-fledged program that allows you to actually respond to the things you need to respond to. So your compliance program needs to be consistent with your size, with your operational complexity, and with your resources. You can absolutely be reasonable about this. You don't need to bankrupt your company to create a compliance program, but you do need to have a compliance program that can respond to the types of challenges you will face as a provider. So if you are just starting out, if you're listening to this, and I am assuming there's probably not too many of you in this bucket since you're part of HFMA and you're attending a compliance related presentation, there's a good chance you already work for an organization that has some type of compliance program in place already. If not, though, do not panic. It is okay. There are some sort of basic first steps you should take to get your compliance program off the ground and to start to really develop a particularly comprehensive risk analysis for your organization. So the first thing you should do is designate a point person. Pick a compliance officer and develop the reporting structure around them and give them responsibility for handling compliance issues for your organization. Develop an organizational code of conduct. It's more common than you think for companies not to have this, or just to think that it's a a document that is one of those sort of nice things that everybody makes nice speeches about at company meetings, but it doesn't really mean anything. Consider your code of conduct as an organization and whether or not it makes sense to bolster it, to include specific references to healthcare compliance, or to include other sort of meaningful direction to your employees and to your staff to really create a culture of compliance. It can be more important than you think, and it's more than just sort of a document that gets framed and hung up on the wall. Once you have those things in place, do a comprehensive risk assessment. So, as I said before, every type of healthcare provider has a different risk profile. If you have a lot of relationships with physicians, you have a lot of Stark issues to worry about. If you don't, then you maybe have less to worry about on that front. And the risk is going to vary based on who you are and what you do. So the first thing you got to do is figure out what areas of risk are particularly acute for your organization. Is it your HIPAA compliance? Do you have a lot of medical records and you don't really know what to do with them? It can be any one of these things. And while you're doing that risk assessment, flag any areas for immediate or obvious concern. So I mentioned earlier the HMA settlement for $260 million. One of the allegations was we're providing free office space to our physicians who refer to us. That would be a sort of immediate and glaring obvious issue that you would want to think about and address right out of the gate. So watch out for those types of issues and take care of those kind of high priority items first. Once you've got sort of those basic elements in place, you have a compliance officer, your organization's code of conduct is set, and you've done that risk analysis. The next step is to really sort of start to build out on those bones, to start to flesh out your compliance program. So start to develop more formal written policies and disciplinary guidelines, focusing first on the areas of highest risk that you've identified in your risk assessment. So again, if your highest area of risk you think is your medical record safety and security, or how you handle and transmit records, really develop your HIPAA policies and procedures first and think about all of those things. And then maybe move to areas of risk that were not as acute for your organization. As you start to develop those policies, you need to incorporate them and begin to roll them out to your employees. So build your employee training program, build the onboarding orientation part of it, and build the ongoing part of it, and make sure that all of these new decisions that you're making, all these risks you're uncovering, all of these plans you're developing are all communicated to the employees, and also make sure they have a way to communicate back with you as well. When you first start to talk about these things in particular, your employees will have a lot of questions, and it's going to be very important that they understand they can come and talk to you about any questions or concerns they might have, and that they can actually, in fact, get information from you if they have questions or concerns. Once you've done those things and you've really started to develop your policies and procedures and you've identified the areas of highest risk, your compliance program is going to start to develop its own sort of cadence. You will start to feel, you'll get a feel for what level of internal auditing and monitoring is appropriate and what areas are of particular importance. You'll get a feeling with regard to how often you need to remind your employees of the various compliance efforts that the company has. And at this point, you can really start to build out the sort of detail for your compliance program that's going to be helpful in making sure you cover the most possible areas of risk. So at this stage, you've already developed, again, to use my example, you've already developed the key HIPAA policies and procedures. But now maybe you have an opportunity to take an area, look at the areas of lower organizational risk, where you say to yourself, this is not a really pressing issue for our company, but we have some latent risk here. And let's make sure that if someone ever asks the question, we have a policy in place that we follow and that we can share to demonstrate that we're a compliant organization. You'll establish your regular schedule for ongoing audits. Again, as I mentioned, you'll get a feel and you'll start to understand how often that needs to happen. If it's an annual process or every 2 years for particular areas, you'll have a better understanding of that. You need to actually start to enforce your compliance policies and disciplinary guidelines. Particularly if you're building a program from scratch, there's going to be bumps and scrapes along the way, and it will take time for your employees to learn and to understand how to interact with that compliance program. But you need to actually start enforcing those policies and procedures, because again, having a policy and not enforcing it is in many ways a lot of times worse than just not having a policy at all. You can also take this time to start to be proactive in your compliance analysis. So you can go beyond figuring out internally what we think the biggest areas of risks are and start to proactively monitor developments and trends in government enforcement. So where there are new or heightened risk areas, where there are new regulations, where there are new requirements for healthcare providers, you can start to actually, dare I say, even get ahead of compliance developments as they come up from time to time. And you'll also want to have, at this point, also a regular reporting schedule to your board and to senior management to let them know about your compliance efforts, to let them know the types of issues that you are seeing on a recurring basis, and also how to help make sure that your board and your senior management are setting their priorities in a way that doesn't put undue pressure on your program. So there's a settlement with Life Care Centers a year or two ago, and the issue was essentially that it was a lot like the Wells Fargo case too, where the government alleged that the senior management and the financial management portions of the provider had set their revenue goals in such a way that the only way to realistically achieve them was to start to fudge the rules about how you billed and collected for those services. And the same thing happened at Wells Fargo, right, where you had revenue targets that were set in a way that the only way the frontline employees felt like they could reasonably achieve their goals was to start creating fake accounts for people. So this is an opportunity to make sure you really work in collaboration with your senior management to set goals and to think about business strategies in a way that can allow your provider to grow, can allow you to be successful from a business perspective, but also to make sure that you're not doing it in a way that's going to compromise the whole foundation later on down the road. Finally, no compliance program is immune from having to deal with turbulence. Right? Healthcare, you all know, is an incredibly regulated industry, and it's virtually impossible for an organization to be 100% compliant 100% of the time, because there are so many rules and so many regulations and so many changing facets to those things that it's just impossible to keep up. So when problems arise, the biggest thing is to make sure that you have a program in place that can react to those issues and respond with good speed. So you want to cooperate if there are outside investigators, cooperate with them and help resolve situations. Engage your internal or external resources as you need to. If you need an accountant to help you run through some numbers, if you need claims analysts, whatever it is, find the right resources to make sure that you're able to respond to any issues. When there are issues, and sometimes there are and sometimes there aren't, make sure you implement corrective actions in a prompt manner. So figure out what the problem is and figure out how to fix it and then move forward, because one of the best ways to show the government or someone else that you are acting as a compliant organization is to make sure that you respond to these things in a manner that demonstrates your organization is willing to work with the government to be compliant. Once you've had that initial response, the second sort of phase to that is really to make sure that you take a look then back at your compliance program. So if there was a billing and collections issue and your compliance program caught it and you figured it out and you resolved it, that's great. You're doing something right. Maybe share with some friends, about the policies and the procedures and the processes you have in place to catch those things. That's excellent. If your compliance program didn't catch it, take a look back at the compliance program and figure out what changes do we need to make. Who else do we need to bring in? Did this happen because we had a gap in our process? Did this happen because we had employees who felt like they couldn't communicate with us? Whatever the issue is, try and identify that and make the changes to the program itself to make sure that you are able to adapt your program to continue to respond to these things. And finally, there'll be times when you have to develop specialized policies and procedures to address sort of specific risks. So when things like credit balances, for example, become an area of heightened interest for the government, make sure you're able to develop as a compliance program sort of specialized knowledge, specialized expertise in how to respond to challenges in that particular area. Because again, that's going to be one way that your organization can continue to protect itself and continue to evolve its compliance program in a manner that lets you continue to provide value to your provider organization. So for those of you that are really heavily involved in your organization's compliance program, this is another tool that you can use to help evaluate your compliance program. In March of 2017, so it's a little older now. The OIG published new guidance to help providers evaluate your compliance program. As I mentioned at the outset, this is your annual opportunity to take a step back and to think sort of holistically about your compliance program, and to see what areas might be ripe for improvement, what areas might need to be updated based on changes in the law. And this is one tool. You can click the link in the PDF that will be able to help you out. So as I mentioned at the beginning, we get a sort of a widespread of people who listen to this call, people who are involved directly in the compliance programs, but also people who are, revenue cycle managers or do other sort of functions. And so I want to make sure that we talk about ways that if you're not part of the formal compliance program, you can help your organization. As I mentioned at the outset, you are the most important part of an effective compliance program. No matter how excellent your organization's compliance officer is, no matter how involved they are, no matter how detailed the policies and procedures are, the pages and volumes of documents the program produces to try to keep up with healthcare regulatory compliance, without your involvement and your buy-in, the compliance program just cannot be as effective as it could be otherwise. Because you're the one who's going to be able to spot issues as they happen and bring them to the organization's attention, in a way that will allow your organization to respond to them without having to worry about as much external influence. So here's a couple things to think about. First is, if you're not directly part of the compliance program, make sure you still learn your organization's policies and procedures. This is important for a couple of reasons. First, more organizations are moving towards compliance as an element of performance, and so there may be sort of an economic incentive for you to think about that as well. But also, just from a compliance perspective, you can't identify an issue if you don't know it's an issue. And so learning about the things your organization cares about and prioritizes is one way to make sure that you can be engaged and actively looking for the right things. If you do see something, if you see something that seems weird to you, say something about it. Go find your program, your organization's compliance hotline or the drop box, or go knock on the compliance officer's door. Whatever the process is at your organization, go and see some. If you see something, if you feel like for some reason you're getting paid more than you would expect from Medicare for a certain service, or if you feel like maybe there's some missing documentation that you would otherwise expect to see on a particular patient file, those types of issues, all appropriate to bring to your compliance program, all appropriate to ask for someone to address, and you can help them work with them to get it resolved. And as part of that, you need to be, I'm calling it curious, but in other words, if you see what looks like a potential issue, don't just wave it off. Don't just dismiss it. If you think that there's a problem, try and figure out what might have happened. For some reason, did we accidentally submit 2 claims for the same service, and that's why we got paid more? For some reason, are we getting paid based on the wrong fee schedule? Try to figure out what those issues are and work and help with your organization to figure out what the problem is, but then you can take that information to your compliance program as well to help them resolve the issue. At the same time, it's not necessary to be an alarmist. There's also sort of a natural inclination, I understand, to if you see a potential issue, want to raise the flag immediately and run down the hallway screaming, "We have a Stark problem, we have a Stark problem." And the thing, you may not. There are a number of different ways that organizations become comfortable with various issues. And there are a lot of, for example, on Stark, there's a lot of different exceptions. For the anti-kickback statute, there's a lot of different safe harbors. And then past that, you still have sort of the intent element on that statute to wrestle with. For reimbursement, as you all know, there are a lot of reasons why reimbursement may be different than you were expecting. So just because there is an issue does not mean the sky is falling necessarily. It does not mean you should not, it doesn't mean you shouldn't report any issues that you see to the compliance officer. You should. But at the same time, you don't need to be in full-blown panic mode when you do it. You don't need to be sort of aggrieved about it. But take the information that you have and you support it and port it to your compliance program, and expect that they'll work with you to help resolve it. One other issue I wanted to talk about before we go to questions, and this is one that's important to me because it comes up for me on a fairly regular basis. In your role for your healthcare provider, there's a good chance at some point you're going to have to talk to the government. It may be, just that you have a question about a particular code. It may be that you have a question about an interpretation of a regulation. It may be that the government has asked you for documents. There's a whole list of reasons why the government might be talking with you. And I'll talk a little bit about how to manage that process and some things to think about. Before we go any farther, the most important thing, follow your organization's policies. So do not leave this webinar and say, well, I'm just going to go call up the Colorado Department of Healthcare Policy and Financing because this guy on a webinar said it was fine to talk to the government. There's a pretty decent chance your organization has a policy about how to communicate with the government. You should learn that and follow that. This is more just about sort of practical advice for when you need to talk to them or you need information from them. Sometimes you need them to give you some good guidance so that you can do your job appropriately. So if you have a billing issue with Colorado Medicaid, for example, you probably need to talk to Colorado Medicaid to deal with it. And when you do that, there are just some things to keep in mind. So the first is they are very busy people, just like you. And try to remember that, and try to remember that they are, if you're sending them a question about a billing concern, they've already got questions about billing concerns from an infinite number of other healthcare providers that they're all trying to manage and work with, and allowing for that will get you a long way to get their good graces, and also will help you understand why it sometimes takes a while to hear back. So for best results, though, remember, if there is a process for contacting the government, follow the process. So if there is for example, a provider relations hotline for the Medicaid program, start there before you go to someone who works directly at the agency. Because chances are there's a process that they want you to follow, and when you get eventually to the person at the agency, they're going to be much more receptive to your question and much more likely to help you if you've already followed that full process, because they're going to care very deeply not only that you're sort of paying attention to what they've asked you to do, but also that you're not just flooding their inbox every chance you get. And if you get a really good contact at a government agency, don't abuse them. If you find a really helpful person who's been kind of sort of key and instrumental in providing guidance for you, don't run immediately back to that person every time. Sort of pick and choose your battles, pick and choose the issues where you really, really want and really, really need assistance. The next part of that is sort of doing your due diligence ahead of time. So if there is a question, for example, let's pretend it's a reimbursement issue for Medicaid, take the time before you call to review the provider manuals, to review the regulations, to review any other guidance the agency might have already published about your specific issue. A lot of organizations publish things like provider bulletins. So see if they've already maybe answered your question in one of those places. Again, I have found that government employees are a lot more responsive and a lot more willing to help you if you can say, hi, hey, here's my question. I understand you talked about this issue in the April 2017 provider bulletin, but my issue is different because X. And if you demonstrate to them that you have, in fact, sort of done that homework ahead of time, it helps a lot. Most government employees want to help you, but they are also going to be wary. So they don't want to provide you incorrect guidance because that's not good for anybody, and they don't want to be embarrassed. So just when you ask questions, try to ask questions sort of as clearly and as cleanly and as simply as you can. Ask for the most direct sort of guidance that you can and try to craft your questions in a way that they're answering sort of the simplest possible version of the question, if possible, because that sort of eliminates or mitigates the need for them to sort of hedge on their guidance or to go farther up the food chain to ask for additional guidance. The more simply you can structure your question, the better. At the same time, also don't ask questions you don't want the answer to. This is part of when following your organization's policies is really important. If there's a question that you have for the government that's a toss-up, that maybe it's a 50-50 answer, you may not necessarily want to go and just ask that question outright. You may want to think about a different strategy to approach the government on the issue. Because the problem is, if you ask the government for advice on a billing question or an enrollment question, a license question, and you get an answer you don't like, you can be stuck with it. And so it takes time before you call, before you decide to engage with the government, that you make sure you understand what the question is going to be, what the possible answers might be. Be prepared to advocate for your position. We think this code should be covered because it is a medically necessary service, and we're this type of provider, and you should be covered for other 3-4 other reasons. That's part, due to doing your homework first. But that's also just part of making sure that you're ready to sort of engage with them in a helpful manner, and then also be prepared to identify the plan B if the guidance isn't helpful. So if you don't get the answer you want to know sort of, okay, well, if we can't do X, then we can do Y. And we are prepared and we can live with that, and it's going to be okay. But make sure you know sort of what that is at the outset. Because if you don't know what it is, that's maybe another signal that it's time to take a step back and think before you engage directly with the government. And when you do get advice from the government, there are sort of a few ground rules that you should think about and be aware of. So if you get guidance from the government, when you're on the phone with them or if you meet with them in person, take really, really good notes. Record their name, their title, and the date and time of your conversation. An important part of this is actually just making sure that the person you're speaking with has the authority to actually offer you guidance. I've more than one occasion called up a government agency to ask questions on behalf of a client, and wound up having an extended conversation with the person who just answers the phones. And they might be really, really knowledgeable, and they might be really, really helpful. In a lot of cases, they are. But if you're dealing with a very, sort of a thorny reimbursement question or license question, you need to get that same answer from someone in a sort of more senior level, because if you're going to be relying on that, you want to be able to know that the person who gave you that guidance has the authority to actually offer it. Once you've had a chance to have a conversation with them, you should end every conversation with the government by asking if you can send them an email to confirm what you've talked about in writing. Or sometimes it's a letter, sometimes it's something else, but to the extent you can, and a lot of times people are willing to, you want to be able to get confirmation of that guidance in writing, because that's a lot more persuasive if there's ever an issue down the road than just your handwritten notes, even though you're going to have taken good notes and you're going to remember the conversation. And if for some reason they won't confirm their guidance in writing, before you rely on it, just again, that's another opportunity to take a step back and consider whether or not there was a reason they didn't want to do it, or if they seemed unsure, or if maybe you weren't talking to the right person. That's just another sort of checkpoint to say, well, wait, before we go any farther, let's make sure that we're really comfortable with what they told us. So last but not least, when you communicate with the government via email, and I can't emphasize this enough, start a new email string. Use a clean email. Do not just forward something that you've received previously from someone else, and be very, very careful who you copy. I've had the opportunity recently to be involved in an investigation in a different state that's not part of HFMA Region 10. And as part of the disclosures that the government shared with us as part of that investigation, there were a number of emails from our client to the government. And in those emails, if you read down them far enough, you would start to see conversations back and forth between two employees of the client. And they were asking questions like, well, is this compliant? Can we do this? What if we do this? Here's what we're doing now. I'm not encouraging you to hide anything from the government, but those types of conversations are better had with your compliance officer, your legal department at the organization. And you want to, when you communicate with the government, avoid inadvertently including any of those sort of internal deliberations, because there are plenty of cases where there is a regulation or a requirement that is ambiguous, and your organization probably has a position as to what the proper interpretation of that requirement is. and they want to be able to to defend and protect that. And if you are including those kind of communications or conversations in your emails to the government, it can compromise those things. So just be extremely cognizant whenever you communicate with the government of making sure you understand everything that you're sending, and that you're making sure that when you reply to emails or you forward emails, that you're not inadvertently copying someone that you wouldn't necessarily want to be copied on that particular email. We've all hit reply all. We all, sort of make mistakes on that regard, but when you're communicating with the government, the stakes can be higher. So before we get to the sort of question and answer portion, I just a couple of kind of high-level conclusions and thoughts for y'all as we finish. A lot of false claims at risk areas are tied specifically to provider reimbursement. You might have overpayment issues, you might have billing and collection issues, you might have any number of potential problems. And having an effective compliance program is really the best way to make sure that you can catch and be proactive about those issues kind of upfront. To do that, though, you need not just an effective compliance program, but you also need, frontline employees who are actively engaged in watching for compliance issues in their day-to-day jobs. They're the ones who are going to be able to identify the issues up front and bring them to your attention. So make sure that you are also engaging with your employees to make sure they understand they're on board and you're all kind of rowing in the same direction. As I said, if you're involved in or actually whether or not you're involved in your compliance program today, your organization, take time to sort of understand what the current program looks like today, to take a step back and think about it from a broader scale if you're responsible for that sort of development for your program. If you're not, to think about what that program really asks of you and your role at the organization, and then focus on areas where there's additional development needed. So make sure that you are paying attention to changes and to trends in healthcare compliance, that you're able to adapt your organization's policies to respond to those. And with that, Nikki, I'll turn it over to you if there are any questions.
All right, great. Thank you, Ryan. A lot of practical guidance. Great presentation. Thank you. Before I take our first question, just wanted to remind everyone to type their questions into that panel located to the right of your screen, and we'll take as many as time will allow. I will address one question about the slides. You can get those right away. Just look to the right of your screen, and there's a handouts panel. Expand that, and you'll see a PDF icon. Alrighty, so our first question is, what reimbursement-related compliance issues do you anticipate will be important in the coming year?
Sure. All right, that's great. Great question. A few ideas for you. So everybody is aware that there's an opioid crisis going on, and that there has been clinically, I think some good news on that in the recent months. I've heard some suggestion that sort of the overdose deaths and those types of clinical issues are kind of leveling off. From a legal and compliance and enforcement standpoint, all that stuff lags like a year or two behind. So we are still going to be seeing, I think, a high level of opioid-related enforcement activity for the next couple of years, and it's still going to be a hot button issue. And for the most part, those types of investigations or audits focus on sort of the clinical necessity of the prescriptions and that sort of thing. Where you can get into trouble from a reimbursement perspective is if you wind up having to do an audit like that and you discover, well, not only do we not have the medical necessity documentation, but maybe our lack of documentation in this case leads to concerns that we shouldn't have been billing for the service at all. So those types of investigations can actually bleed over into reimbursement, even though that's not really the focus of what everybody's looking for. So that's just something to be cognizant of if you have to deal with an opioid-related issue sometime over the next year or two, to keep in mind, keep an eye towards that as well. Hospital provider-based status, if you are at a hospital facility, CMS is still all over provider-based facilities. They do not like them. They do not want them, and beware of CMS looking for opportunities to challenge your compliance with those requirements on a regular basis. Two really broad areas to think about. There's been a big movement here in Colorado, and I think nationwide as well, towards consumer protection in healthcare, to making sure that there is, for example, the new CMS requirements on hospital price transparency, to make sure there's information available to consumers to help them navigate the healthcare system in a way that is meaningful to them. I think you're going to continue to see more of those requirements develop over time, and that's something that you may want to use your compliance program to focus on to make sure your organization is meeting those thresholds as they become applicable to your organization. Last, I will say that we are in a regulatory enforcement environment right now where CMS and the government in general has indicated their desire to reduce burden for healthcare providers, which sounds really great because we want to make, if they're going to relax some technical requirements, maybe that can be things that help providers manage their risk and maybe respond to audit investigations in a way that is more straightforward because there's just we might have more arguments available. The challenge with that, though, is that burden reduction does not always mean things become clearer, and it doesn't always mean that things become easier for providers. So one example I'll give you is, CMS repealed recently the regulation that required Medicare providers who terminate their participation to advertise that in a newspaper. They did not change, however, the requirement that you still notify the public that you're terminating the Medicare participation. Now, in some ways, right, removing the newspaper requirement makes sense because who reads newspapers anymore? But at the same time, you still now have, in advance of that sort of black and white requirement, instead of that black and white requirement, you have still this sort of broader notion that you need to notify the public and a lot less clarity about what that means. And so you still have to comply with the requirement, but you no longer sort of have the check the box thing you could do before. And that applies to reductions, for example, in signature requirements for certain orders or medical necessity documentation. Even if they remove some of those sort of check the box tic tac requirements in the name of reducing burden, you still have to meet the underlying thresholds. You still have to have medically necessary services. You still have to have orders. And so you want to make sure that even where they have reduced burden, that you are still meeting the sort of substantive compliance requirements that are still out there.
All right, thank you so much for that, Ryan. All right, so our next question, how often should my organization be conducting internal or external compliance audits?
Yeah, so again, that's a great question. It's going to depend on what your organization is and how big they are and how heavily involved they are, and it will depend on the risk area too. So if you are a large organization, there isn't a magic number that I can give you, but you can think, if you're a large organization, think about annual audits for certain maybe types of medical necessity documentation or other key service areas that are really important to your provider. And maybe you think about, every couple of years or more for sort of a larger audit of your compliance program generally. That's a sort of, I guess, a tough question to answer, but it's really just going to depend on the resources that your organization has to bring to bear. And then you can also, the other thing is you can talk to your peers too. If you are a lab company, talk to their labs and figure out what they do and sort of work with them to develop a plan that is going to be consistent with industry practice and standard.
All right, fair enough. All right, I like this next question. I like all of them, but is it my organization's fault if Medicare or Medicaid pays too much because of a government system error?
Right. So it's not your fault, but it does not mean you don't have to pay the money back. That's the unfortunate part, and we hear this from clients all the time is, this was Medicaid system error. Why are they coming after us for money? And unfortunately, the definition of overpayment is any money you're not entitled to, regardless of whose fault it is that you have that. And I would say a particular note for any of you that are in Colorado, Colorado Medicaid continues to have, I think, some issues implementing their new claims processing system. They implemented their new system in March of last year. So it's been now a year and a half. And just, last week, we encountered an issue for a client where they were not being paid for certain codes, and it was because of an implementation error for that system that had just been lingering for a year and a half, and no one had triggered it yet. So there are still issues out there, still things to be cognizant of, and unfortunately, it doesn't matter if it's Medicaid or Medicare's fault at all. it's still something you have to monitor for and be aware of.
Great. Okay. Well, it looks like we've exhausted the questions that have come in. So I would just want to give the audience just a couple moments if they're gathering their thoughts to type in a question using that questions chat panel located to the right of your screen. In the meanwhile, just wanted to let you guys know that HFMA will also be hosting a Women in Leadership Fall event on November 8th. You can check out get more details about that at the website hfma-co.org. Let me try that again, hfma-co.org. And as Ryan mentioned, as we close out today's webinar, you will automatically be routed to a survey, and we would really love to get your candid feedback about today's event, as well as other topics that you'd like to see on future webinars. All right, Ryan, I am still checking. I don't see any questions that have come in, so it looks like everyone make it the gift of time, about 6 minutes or so. Right. I do want to take this time and thank our members and the healthcare community at large for joining this call and supporting the Medicare Bootcamp webinar series hosted by HFMA Region 10. And thank you again to our guest speaker, Ryan Thurber, Associate at Polsinelli, PC. Ryan, we really appreciate you not only presenting today, but always supporting and hosting and managing these webinar series.
Oh, it's our pleasure.
All right. Well, have a great afternoon, everyone.